Hi. So, hi everyone, this is Lahiru and I'm here with Kaz and we're doing some more interview techniques. So what we're going to go through today is clinical questions and lateral thinking questions. So that's what we're going to go through. Thanks for joining us and we'll get started very soon. So what we're going to go through, Kaz, is some clinical questions and lateral thinking questions. You excited?
Very, very excited. So clinical questions tend to get asked, with varying frequency, but they are becoming more and more frequent. So, Lau, what's your approach with these ones?
Yeah, so I think the first thing to know is that when you get asked a clinical question, you're a resident, right? So you're maybe a HMO 2, 3, or 4 if you're going for quick care jobs, maybe it's senior for other jobs. And what I find is that I don't think the examiners can really expect too much like a consultant level answer. So what we did when we constructed our clinical question, or pretty much this is what I did, I just constructed a question that could be interpreted in a very complex way. So, it was a question of someone, having having a bicycle accident and they've fallen and broken their wrist. And so they're in quite excruciating pain, even after a normal trauma assessment. So we made it kind of simple in that the rest of the trauma survey is normal, but you've got this really severe 10 out of 10 pain in their wrist. Now that has so much complexity in pain management. And so, you could ask a pain physician or a senior anaesthetist who's interested in pain management and get a really comprehensive answer. But essentially what I wanted to see from junior staff is that they had a framework. So clinical questions, this is all about frameworks. If, just like we've said before, give me the list before the detail. Clinical questions are the same. I want to know that you have a really good structure, because then as you learn things in the future, you will not miss anything. You'll have a really great framework and skeleton to add on a whole bunch of knowledge to. So in this particular question, when you think about pain management, I'll try to structure it in a way that we can translate the structure to many different things. For example, it's usually a serious thing, so I'll say, well, I'd immediately attend to the patient, and then I'd do what I do for any sick patient or someone in severe pain or who's otherwise unwell, which is the standard deteriorating patient A to E assessment, which involves escalating, calling for help if you think it's required, and then A to E assessment. Now, I wasn't too fussed with people going through the A to E assessment because this was about pain. But as soon as they started with that, I said, oh, fantastic, that's great. I'll volunteer some information about how, tachycardic or hypertensive they are, and if there's any other issues. So this is not really to test their deteriorating patient ALS style knowledge and frameworks, but I want to know that they'll do that first. Then the next part of that structure, so we've said would attend immediately, call for help, A to E assessment, which you do for any sick patient. And then there's the framework for the question in particular. So then if it's pain, I do a history examination and investigation of that pain or whatever else the problem might be, whether it's fluid problem, dehydration, fluid assessment, chest pain, shortness of breath. I would then do my history examination investigations of that. And my management would pretty much be of the framework of I would have a biopsychosocial approach, pharmacological and non-pharmacological. My pharmacological management is usually multimodal, which includes this, this, and this. And my non-pharmacological management in this situation would be something like immobilization, contacting surgeons, scheduling a theatre time for fixation or whatever they need to do. And finally, thinking of any other serious causes. Now, so other serious causes would be things like compartment syndrome, vascular compromise, maybe even nerve entrapment or nerve issues. And just to say a few of these things that I'd be concerned about. Now, just to remember, I'm a consultant anaesthetist who has probably done a lot of pain management, but there's nothing in that answer that really was that advanced, which is attend the patient, call for help, A to E assessment, history exam investigations, pharm, non-pharm management, and a bit of detail. And everyone knows what multimodal is. Everyone knows what non-pharmacological is, and then some serious stuff not to be missed. What do you think of that?
I think that you're on the program. Well done with that sort of an answer.
I wouldn't have been able to give that answer back in the day, though. But so again, in my experience now, over Zoom, it's really hard to gauge. For the candidate, the trainee being interviewed, they're not really going to know how much time that they're necessarily going to have for this question. So the only way you combat a setting where you don't really know the time frame is to show your structure and then slowly add detail. So they've already got the framework of an answer. The interviewer already knows that you're going to talk about all these really useful things, and they can cut you off if they need to, knowing that you've got a good structure. So that's really all I'm looking for.
So what I really like about that answer is, so I think the structure is really great, and I think you've essentially just kept it really simple. You've said you have any patient in front of you, we all automatically do a doctor's ABC assessment. Like, we do it cognitively by the time you're PGY3. And if there's any aberrations in that assessment, you would address it appropriately. And it's just about, I think, articulating that. And I think that's what I remember finding really hard about clinical questions as a resident is what I did in real life and what I say in an exam is really different. And it's only when you start studying for the exam and you start actually doing clinical vivas that you start to bring the two together, that your communication about what you do in a scenario actually matches up with what you do. And you probably notice this, teaching lots of residents law, that if you put someone in a situation on how to manage hypoxia, they'll probably do it right. But if you ask them about it, they get tangled. They go, oh, well, VQ and this and do that. But essentially, what would you do? You turn up the FiO2 and you check the circuit, in patient 2. And that's the first thing you do. And I think where I find residents struggle a lot is they haven't practiced doing that. And I think clinical questions are, as with a lot of questions, but something where you can improve incrementally if you just practice it. And I really like to put myself in that position. So I use my imagination and imagine I'm in front of the patient and I actually talk through what I would do. And that's so much easier than trying to think abstract.
That's such a good idea. So you don't miss things. If these are just words, two people talking over a screen.
Yeah.
But if you imagine yourself in that situation, there's a lot of mnemonics and memory aids that you will get just from the fact that you imagine yourself in a situation. I think that's a really useful tip. That I hope most people, even in the final exam that we coach for, will hopefully do that as well.
Yeah, exactly. And again, it's all down to practice. And I think doing a breadth of questions as well. So, that was quite an interesting question. I'm very used to having lots of anesthesia, deteriorating patient on the ward type questions, because that was kind of almost you're an ED resident in ED making this assessment, which is a great scenario because it expects a lot more lateral thinking than just being, oh, I'm an anaesthetist, I'm here to look after the airway and pain, which is a mindset we tend to get to.
And I feel like, especially for a crit care year, it's almost unfair to have anesthetic questions because there's varying amounts of anesthetic experience, but correct. Everyone's managed a fracture or helped manage a fracture in emergency. And so I guess, if you were to ask me, what would be the questions you want to absolutely know how to answer? I think it's just the basic stuff, so that you would be expected in emergency or as any medical or surgical intern or resident on the wards. And these would be things like, how would you assess dehydration in this patient? How would you address or assess manage volume loss or hypotension? How would you assess poor urine output? And literally, those are the same things. So if you think about poor urine output, I would literally just say, 0 mils for 3 hours, that sounds serious. I'd attend the patient, call for help, A2E assessment, and try to optimize any hemodynamic parameters that were not great. And in the meantime, I would think pre-renal, renal, and post-renal causes, and then just go into a bit of detail and say a few words about each. Because realistically, renal failure is very complicated and very tough to solve and manage. But the actual motion of doing things at a junior level is not too bad. Post-renal, bladder scan, check the catheter isn't kinked. Renal causes, are they on renotoxic medications? What's their pre-test probability? What's their history of or likelihood of having this, diabetic, hypertensive, etc.? Or have they just had a massive operation with lots of blood loss? And then pre-renal, essentially, what is their volume status? What's their fluid balance? What's their blood pressure been? Are they actually able to perfuse this kidney? And if not, what am I going to do to fix that? So, you don't have to get into that extra detail I gave, but if you said those first things and had a structure for renal failure, pre-renal, renal, and post-renal, I think I'd score you very highly.
Yeah. And I think with clinical questions, the other thing to consider is that there's kind of two styles at this level. One is the kind of the style that you asked, which is you give a scenario and you let the candidate work through, start to the end. And often you can integrate non-clinical aspects into it, like, M&M escalation to to WebAIRs and stuff like that. But then there's another style, which is more the Viva style, which I've only had once, but it's essentially you give a clinical scenario, and as you're working through it, they cut you off and they go, well, the BP is now 80, what do you do? Or the BP is now 60, what do you do? The patient's now tachycardic. This is the ECG. What rhythm is it?
Wow, that would be pretty intense as a junior.
Yeah, it was very intense. And I've only had that once, and I found it really hard because all the interviews, practice I've done, and all the clinical scenarios I've had been the question and then let me kind of work my way to the answer. So that kind of Viva style is, again, something to prepare for, I think, because that is what a Viva is, and you'll be doing it for the rest of your life.
Yeah.
So another question, Lars. So one of the things that one of the structures that I really enjoy from what you teach is when you're trying to diagnose a deteriorating patient, you have the probability gambit, and you have, what is the worst thing? How would you incorporate that into this question?
Yeah, that's good. So if that's definitely advanced level stuff. So, but let's say you get something like hypotension in a patient. So let's give a scenario of a post-op anterior section who now has blood pressure of 80 on the ward, and let's say everything else is kind of normal stuff, nothing too outward on that. Then what I sometimes integrate after I've done my attend, call for help, 80 assessment, my framework, and then talk about, I would do a history, examination, investigation after stabilizing the patient, and now I'm targeting why is this patient hypertensive. I would then volunteer that this is most likely this. The serious things I want to rule out is this. And if those things aren't correct, I would then adopt a framework, which would be, for me, hypertension is causes are preload, rate, rhythm, contractility, and afterload. And so what I find in this is they talk about how as you get more expertise in the field, people use probability gambits because they've got so much experience that most likely that an elderly patient post-anesthetic on the wards with hypertension is probably vasoplegia post-anesthetic and being elderly. But the serious things I really want to rule out are some kind of volume loss because it's, it was operative. They're elderly, so they've maybe had an ischemic event, so the contractility is a problem, or maybe they've had some antibiotics and now are vasodilated due to anaphylaxis. So I'm now talking about three very typical things. I'm not talking about a pneumothorax. That doesn't seem like a thing. And I'm not talking about DVTP because that would happen days later if maybe they're not on Clexane and they've got a malignancy. So I'm really using my clinical acumen to say that I'm really going to look at some reasonable probability stuff and some serious stuff. And then if I'm wrong about that, I've got a structure to fall back on. In my website, so www.anaesthesiacollective.com, I've got some resources. And one of those is just a set of tables full of all the different problems that you might get: hypertension, hypertension, hypoxemia, et cetera, and just the tables and frameworks that I have. So I would recommend everyone make their own tables of differentials, because just the process of writing those out means that you'll have this structure for everything in your head. And as you get more senior and senior, 10 years, 20 years down the track, everything will just be so much easier because you've got a structure for everything.
Yeah, and I definitely use those tables when I prepare for the interviews, and just for the common stuff like hypotension, tachycardia, hypoxia. I think those are the three, the holy trinity of the patient at a resident level. And I think if you can address those, and again, you just need a reasonable answer. And I think again, with these questions, if you have, so let's go back to hypotension. So one of the questions I ask candidates is, if you have post-induction hypotension, what would you do? And you go through ABCs, and you work your way through it. But also, like, if you have hypertension in theater, do you sit there checking the airway and making sure they're ventilating properly? No, you address the aberrant variable, which is the blood pressure. So you give some fluid and you give some vasopressor, and then you'd work through everything. You go to airway, make sure that they're not bronchospasming, check the airway pressures, and you'd work it through the list. But I think you need to show also that, I think the way you show you have experience a little bit is by showing that you get that the most likely cause of post-induction hypotension is an overzealous propofol dose, or having the SIBO running up too high for too long. And I think showing that just shows that you have a bit of experience. And I think that's how you would differentiate yourself from, if you were a PGY3 or PGY2 candidate applying for a quick care job who has a bit more experience, or you are someone applying for the college with a really good quick care year where you've done lots of anesthetics in ICU versus someone who hasn't. That's a good way to show it, that you have that experience. So I agree that you probably don't need that advanced level of thinking, but I think just showing that you know what the horses versus the zebras. Is it the same? You know what I mean?
So absolutely, and just a bit of plug. So the course that I run, the ABCs of Anaesthesia Bootcamp, I've got all the videos for free on YouTube, on the YouTube channel, and the particular playlist is the ABCs of Anaesthesia Bootcamp playlist. And the video there that I've got is just a framework. It's like a four phase framework for crisis management of any sort of problem solving. And so phase one is doing all the initial things. So checking your reading, calling for help, potentially asking the surgeon to stop, and then scanning your monitors, the patient and the surgeon. So I call that CHESS, CHSS. So confirm reading, call for help, scan your patient surgery monitors, maybe stop the surgery. Then phase two is what you're talking about, the practical stuff. You don't go straight to A to E in the anesthetic context because things happen a lot quicker. You temporize measures. So phase two is temporization. And for hypotension, it's really just give a bit of fluid, give a vasopressor, which most people after 3 months of anesthetics will be very comfortable doing. And then the final phase three and phase four, these are more complicated. Phase three is diagnostics and phase four is treatment. And we kind of go on through a bit of how to get through those. But yeah, if you want to see the whole video, it's probably a reasonable 1 hour lecture on that. And I think it's pretty useful to go through, especially if you haven't got a structure already.
Yeah, I highly recommend that. I think that gives a very useful foundation to then answer really any clinical question, even if it's something you haven't really seen.
Yeah, sounds good.
So why don't we work through one more clinical question if you want?
Yeah, absolutely.
Yeah. How about I'll ask you one?
Yeah, sounds good.
You can on the spot.
On the spot.
So I haven't been asked this personally, but it's kind of made its way through the grapevine of the interview question. So
yeah,
here, you are a critical care resident, finishing off a shift in theatre, and you're the last one in theatre, and you're walking past recovery when you notice there's an unattended patient with the Larry mask inside you, an LMA, and you also notice there's some green fluid coming out of the esophageal port, and the patient is unattended. What would you do?
Okay, so there's immediate things and then system things to worry about. But right now, I'm going to worry immediately about patient safety. So first of all, I might highlight the fact that this sounds very serious for risk of aspiration in a patient with an unprotected airway, and so immediately I'd call for help. Especially as a crit care resident, you don't want to be maneuvering airway devices and having to reintubate without this. So first of all, call for help because you'll need everything at your disposal to sort this out. Once help arrived, I would then be able to manage this. So while help was arriving, I'd probably do all the things that I need to do in general for any patient that I could reasonably do as a crit care resident. So some of those things would include having the patient monitored, increasing the oxygen to make sure that they're well oxygenated. So that's my safety stuff. And then finally, trying to temporize things. So temporization in this setting, I haven't actually taught before, but the things that come to mind would be to use suction, which is at every bedside. So suctioning out around the LMA, or even with the suction port, if the LMA is a pro seal or one with the extra gastric port, and that might decrease any further harm for this patient. And then if I had a number of hands and helpers, putting the patient in the left lateral position may be something that would be useful. Now, that's probably most of the things that I could think about doing. Whether you go head up or head down, they both have their risks and their benefits. So I wouldn't really, be very passionate about doing either. I would do the position that I could best manage this airway, which is probably slightly head up, so I can, appropriately give a jaw thrust and maintain the airway, because this patient's now at risk of other things occurring, which is, as I mentioned, aspiration, but also laryngospasm. And if they do laryngospasm, negative pressure pulmonary edema. Now, everything beyond that point for a crit care resident could be far more tricky. For example, what is the cause of this patient regurgitating fluid? And if I need to manage it, it probably means removing the LMA and then getting control of the airway, which probably means an endotracheal tube, which is a relatively senior technique and unsupervised. As a crit care resident, it probably won't be something that you'd want to do, because if you do this wrong, patient dies. Whereas right now you've got a patient who may become sick with an aspiration or laryngospasm. So at this point, I would probably, as a junior, you can still, even though you're not allowed to embark upon these dangerous techniques, I find it really useful to tell what I would expect to do, because then I'm showing that I would get things set up for the senior help that arrives. What am I thinking? The things that I would like to get set up is everything for reintubation. So what I need, I want my 4 M's so 4 M's before an intubation. I would get my airway equipment, Mabel's, mask, airway, bougie, EDT, laryngoscopes, and suction. So I'd organize someone to get that. I'd get my meds for rapid intubation, which is propofol and sucks, maybe opioids, but not absolutely necessary. So that's Mabel's or airway stuff, meds. I'd check my monitoring. My essential would be end-tidal CO2, SATs, blood pressure, maybe ECG. And finally, I need something to ventilate this patient with. So that might be actually moving the patient to theater for the to get the anesthetic machine there, or having a Lateral bag ready for that as well. So I may have not been in the position to do this myself. I'll get everything ready. So as soon as the consultant arrives, I can do ISBAR handover and get that stuff ready. Finally, if the more advanced management, which I wouldn't expect crick care residents to know about aspiration, would be the fact that you need to bronch this patient. You need to anticipate and plan that there could be solid things in there, that you have the risk of volume injury, acid injury, and particulate matter, and you might need to be able to sort that out with a bronchoscopy. And then I'd think about anticipating and planning what the destination is. That this patient probably needs ICU, HDU, depending on what's happening with the other variables, if their saturations decrease, and you may need to manage that in a HDU setting for a period of 24 hours to get a chest x-ray, rebronch, humidified oxygen, maybe even steroids, and potentially antibiotics later if there's signs of infection. So I think I've covered most of my management plan there. That's just on the fly. So sorry if I missed out anything.
No, I think that was great. I think that's some of that latter stuff was very, very kind of part 2-ish, I think high level stuff. So you wouldn't be expected to do that as a crick care resident. I think as a crick care resident, what you said was exactly right. Like up to the point of suctioning the airway, making sure monitoring's on, and you've asked for help. That's probably as much as you'd ever be expected. Even as an anesthetic registrar, you probably go a little bit more and know a bit more about how to prepare for re-intubation and think more about the logistics of, do you go to theater, do you go to HDU, what do you do, get some staff. And then the other stuff, I think it's excellent if you can mention how you would manage an aspiration, but definitely I think you'd be pushing the 100th percentile of even a college interview. Really, would you agree with that?
Yeah, definitely. Yeah. So I hope I mentioned exactly the point where to stop at, that you wouldn't be expected. So no one be alarmed that this is an anaesthetist talking about this, not an actual crick care resident, but still a crick care resident could definitely imagine all the things without the absolute management of an aspiration. Imagine how far you could get with the right framework: attending, monitoring, and ADE assessment, temporization. So calling for help in the phase 1 type stuff, phase 2 temporization stuff. That's still basic. And then diagnostics and treatment. You can have a sense of that you need to intubate this patient, and every crick care resident should know what you need for intubation. I think that checklist is something, if you've done an anesthetic rotation, you would do every morning before you embark upon your anesthetic. So up until that point, I think that's pretty fair game.
So how would you fit in kind of the higher level, and I guess a higher level in terms of the non-clinical stuff? So this is a clinical situation and you've addressed the clinical stuff. What about the other salient factors? So the fact that as a resident, you're the only person in theater. There's an unattended patient with an LMA, which is definitely not protocol. And I guess the other escalation stuff of addressing escalating this to M&Ms, web airs, and things like that. Do you think that's important to include?
Yeah, I think mentioning it at the start, like I mentioned, just there's the immediate thing that really is what I'm going to talk about. But then afterwards, all the system stuff. Why did this error happen? So I think that's definitely worthwhile mentioning. I doubt that unless they asked you to focus on it, I doubt that would happen. But anytime an adverse event of any sort happens, then I try to make this as my bundle of care, really. So, you've got to escalate to your supervisor, director, your internal kind of personnel, as well as the risk man system, which can then be audited by various governance bodies, and then finally your own indemnity provider if it was your potential incident, as well as the broader anesthetic incident monitoring schemes like web airs. And so I think just having those as a quick bundle to state, I'd report it to my supervisor, risk man for the hospital itself, web airs for anesthetics, and personally for my protection, medical indemnity. And potentially you'd want to audit yourself. Maybe you'd write it up in your logbook as something that happened if this was your thing. Other systems things then probably not in your scope of practice really. Like, why wasn't there someone there? That's probably something you'd raise and it'd be discussed at a high level.
Yeah. So just, there's kind of 3Ds that you can use to structure this. So I love my mnemonics.
Nice.
So 3Ds, so disclose, so open disclosure to the patient. Probably less relevant for this, but if there was another adverse event, it's important you have open
completely
disclosure.
forgot that. Absolutely. Open disclosure to the patient would be an absolute part of that. Nice.
Yeah. So open disclosure, discuss. So I put discuss as in discuss with the consultant, and then escalate, and then discuss as a department, and then escalate even further to WebEx for the ANSCA discussion. And then debrief. So after any clinically adverse event, you always should and have a debrief. If it's not organized for you, you should seek it out. Mm-hmm. And this happens, all the way through. Like I think every clinically significant adverse event I've had a debrief with a consultant or a mentor, and I think it's really important you do that. So those 3Ds, I think, kind of cover everything on this.
I like that. I'm gonna adopt that framework, the 3Ds. That's part of me now. So I love this. Kaz, anyone teaches you something, great. Now that I'm going to adopt that because that's really useful. So disclose was the open disclosure, absolutely a part of good practice. Discuss was all the things we already mentioned about reporting locally, clinical governance, risk man, WebEx, and your medical indemnity, and then debriefing. So that's for your own and the other staff, especially if there's a critical incident. Excellent.
Yeah. Awesome. I think that's probably good coverage of clinical questions. And I think, again, patient safety, knowing your limits, knowing that you're quite junior, and
frameworks.
And frameworks. Yeah.
That's right. Okay. For the next one, the lateral thinking questions. So I think these have been done in corporate settings for a while, but I think there was a period of time where we'd hear about these lateral thinking questions that were appearing in the anesthetic interviews. Now I've got strong opinions about these questions. I think lateral thinking questions are really good, but I think any kind of pseudo-psychological testing questions, I just don't agree with at all. Now, so the difference between these would be something along the lines of, if you were to choose an animal, if you were to become an animal, what animal would you be and why? And so you might just pick, something like a bird and say, because they have so much fun and they're free and they get to fly and this is enjoyable, or a dog because they're so loved and they're loyal and things like that. To then make a statement of judgment of someone's personality based on one question like that, I have a lot of trouble with, and I just don't think that's a good way of doing it. I'm no psychologist, but I just can't imagine. Interviews are problematic enough because it's such a short time frame that people can pretend to be good clinically in an interview. But I think psychological type questions or pseudo-psychological questions are just fraught with danger. Now, whereas something along the lines of a problem-solving question that's really difficult or potentially really difficult, such as how many people buy white cars in Australia every year, or how many Coca-Cola cans are drunk in the world every year, or how many hairs are on your head. Now, that's a problem that requires you to think about how you would answer it. And, I remember discussing this with a mate in the corporate world, and I just started kind of going on about, well, I guess you could take an average of studies and look at some research about hair quantity in certain age groups. Or maybe you could just count the number of hairs on a square centimeter of someone's head and multiply that out by a rough estimate. And I just briefly started saying my process, and he said, yep, great, you passed.
Yeah.
Just to see that you're not overwhelmed by a problem and you have a framework. Again, this word framework, a framework or a process to find a solution that isn't that hard. It's not hard to come up with that. But definitely a lot of people would get stuck on that and think, oh, well, that's crazy. Why would I ever do that? Your ability to explore the hypothetical, show a process, show a framework, I think is really potentially really useful. Again, I don't have the actual evidence for that. It's probably something I'm going to look up over the next few weeks. But yeah, what are your thoughts?
I think I agree. I agree completely. I probably don't have as strong an opinion on the pseudo-psychological questions just because I don't know enough about it. I've always just been on the receiving end of them a lot. I think
in interviews?
Less frequently, but more in med school interviews. They were really sexy for a while.
Really?
I remember, they just kept asking them. I think there's one uni that almost exclusively asked like that sort of lateral thinking, random pseudo-psychological questions. They didn't ask any medical questions, like any why do you want to do medicine questions.
Really?
I can't remember who it was, but if like everyone knew, it's just what they did. I think it's gone out of favor, but
I do remember Monash interviews used to have a detechnicalization question, you know, explain the periodic table to a 5-year-old or to a 10-year-old, or, you know, explain what isomers are. And I remember we would practice for these questions because we heard that was the thing. I find that's a really interesting one, really good one. Puts you on the spot. You got to think on your feet. Again, who knows what the validity of this is, but I could see the logic in that.
I remember doing those too. I think that's much more about, can you break down a concept and explain it? And I think they give you like 5 options. So if you did have quite a few you didn't know, there was bound to be something you would know.
Yeah, we were allowed to pass on one of them.
Oh, interesting. Yeah. So look, I agree with Lahiru. I think don't try to, if someone asks you what kind of animal are you, don't try to think too much about it. Like, the way I think about it is, what you want to show them is that you don't freak out, that you can stay calm, and that you can kind of have a bit of fun is what I would take away. Like, can this candidate have a bit of a fun with the interesting different question, or do they freak out and go, oh, you know, I'm a husky because I'm super loyal to the department and I'm always on time and I'm really good at following instructions and, you know, I'm very smart. You know, that's just a bit intense, and I think you would almost go, that's a bit much. Like, whereas if you kind of go, I'm this animal because, you know, like, I like to eat, or I like to hang out with other people and I get lots of enjoyment from exploring. I think it's a way of telling the examiner a bit about you. And I think just think genuinely. And I guess also try to be a bit unique. Like I always want to say a dog because I think I'm intrinsically like a dog, but I think if you want to say something that's a bit different, it kind of makes them go, oh, this person thinks they're a flamingo. Whatever.
What? So would that be, what if you had to pick when you had to answer that question? What did you say?
I actually can't remember. Actually, no. One of my friends who I interviewed yesterday said when I was applying for internship, the apprentice said I was like a wolf. and I think again I was trying really hard. I think I was talking about like being in a pack or something like that.
Okay, yeah. So as much as I say I don't agree with the pseudopsychological type questions, that's my assumption. Maybe it's just an icebreaker question. They just want you to put at ease, have a bit of fun. Now the thing is, so the only thing you could do wrong in this situation that's within your control is to stumble on this and not answer it and object to being asked this question. So I completely agree that if you get asked this question, just have a bit of fun with it.
Yeah.
You know, say what you like about a particular animal, and you know, see what happens. But if someone doesn't give an answer, that's probably not great.
Yeah, exactly. And there's another version of this that floated around, which was you know, what do you do if you find a penguin in a freezer?
Yeah.
I think this is one of the quick cat questions a few years ago.
I heard about this.
Yeah. So I think that question again, I don't know what they were looking for. But what I took away was it again, like, that's a really random thing, and most people would freeze. Well, one of my good friends actually,
ironic that they would freeze and the penguin was in the freezer. That's brilliant.
Yeah.
I would definitely make a pun about that and just wait for the laughs and just sit back and drop my mic.
Because I'm freezing a bit, much like the penguin. I think one of my friends actually just assumed the penguin was dead, so said that she wouldn't want the penguin to thaw, which I think was a hilarious assumption, which the interviewers just cracked up and said, no, the penguin's alive. I think one of my friends just said, I would just play with the penguin while I wait for RSPCA to come, because how often do I get to play with the penguin? And I think that's just that shows your personality. And I think, you know, this friend of mine is like a very fun, easygoing guy who would do that.
I think there's consent issues there. Why would the penguin want to play with them? but you're right. That's not too crazy, but that's again a process question.
Yes,
you value the penguin's safety and don't want harm to come to an endangered species, and there's a process. You keep this. It's almost like that's your patient. They're in a foreign environment. Patient safety or penguin safety. Get them to safety. Call the relevant bodies. and then just debrief yourself
with the penguin. So I think those questions, I think essentially what we're saying is, don't overthink it, have a bit of fun, show your personality, be a bit more relaxed, and I would definitely practice it every now and then, because they do come up and you don't want to be completely caught off guard. Now the other questions, which are the problem solving ones, I again think this is much more about what do you do when you're faced with a seemingly insurmountable problem to solve. And it's just about going back to basics. So a version of this that I've asked recently is, how would you determine how many cannulas are used in an operating theater over the course of a year? you know, and you usually what you want people to do is, oh, well, there's, you know, like 6 theaters at Footscray, and in each theater there's 2 lists per day, and then each list there's between, you know, 2 to 6 cases depending on what specialty. So you average that to 3, and then you just multiply that. And another candidate,
they'd probably even stop you at that and go, "Yep, they got the process. Great, let's move on."
Exactly. And another side of it, which I didn't think of when I asked the question, which someone told me, was they're like, well, you know, it depends. If you want to estimate, that's what I would do. If I wanted to be a bit more scientific, I would just assess the stock on the 1st of January, assess the stock on the 31st of January, check how much was ordered in between, and I'd make a guess based on that. I'm like, that's great. That's really good lateral thinking. Or you could, and then one person even like incorporated, well, you know, I would look at which theaters had a resident and then double them on a cannulas for the resident missing the cannula, which I thought was really funny. And again, that just, you have a bit of fun, and you make it interesting. So I think another question is, how many pencils are there in the world? You know, give 10 users of a pencil. So I think with those questions, just go back to basics. How would you approach it? And I would assume that the intention of this question is, when you're faced with a problem in the clinical setting or in the non-clinical setting, can you just be reasonable about how you would go at approaching it, or would you freak out because it's not something you've prepared for?
Yeah, and I do put a lot of emphasis on that. I think, you know, you'd be surprised if you have fun with this. Ask other people these questions, just to, you know, if you're about to embark upon, you know, some kind of application process, you're going to get to an interview, you almost do want to immerse yourself in this whole process, just for fun. Next time you're at dinner or at drinks with friends, just ask a bunch of these random questions and see what people come up with. Because I think once you've done this a bit, then it becomes easier. It becomes more playful, potentially. We're not saying don't make a joke about things, but just the fact that you don't have to be this doesn't have to be a daunting process, that it can be quite enjoyable. I definitely, by the time I was doing my interviews, after a lot of practice, I didn't feel as nervous. Like I felt nervous for sure, but I enjoyed it because I felt I was really prepared and I could answer most things with confidence. And I had a good CV and a lot of hard work to back this. So I felt like I deserved it. And I think a lot of that mindset comes in with just preparation and immersing yourself in this process.
Yeah, exactly. So look, you know, interviews, like anything, you know, preparation prevents something poor practice. And I think, I think I've said this before. I think this whole idea that you can't and shouldn't prepare for interviews is really incorrect, and I think it puts a lot of people at a false sense of security. And I think the key thing is here, you know, everything we've talked about, this isn't about gaming the system. This isn't about lying. This isn't about covering who you are. It's a skill. It's a skill to stand there and talk about you in a way that's not arrogant, that doesn't sound weird, that doesn't make you uncomfortable, and it's something that you will generally have to do for the rest of your life.
Might as well get good at it. Might as well get used to it.
Exactly. And you know, the people that get into quick care jobs and anesthetics, I can guarantee there's only a small proportion who don't work really hard for them. And some people are lucky. Some people just happen to have a lot of these skills naturally. You know, and that's great. But I think a lot of people also don't. So you know, the key things, like if you are in the process of applying, I know some of the quick care jobs are already kind of starting to be filled. If you've applied and you're waiting to hear back from an interview, start like now. Don't wait till you get an offer. That's already too late.
Yep.
You know, you might be able to get by if you're really lucky and you're naturally a good speaker. But these jobs, and you know, like we'll probably talk about this next time, but like, you know, there's about 200 to 300 people that apply for a handful of positions. You interview what, 20% of them?
Yeah, so we had 150 applicants, interviewed 20. It is extremely competitive. And then we'll talk about this more in the next episode, but essentially the interview will often be the decider for many departments choosing. So maybe it's not natural, maybe you're not extroverted, maybe your Zoom connection's not working, maybe you're really bad without the face-to-face. You know, you don't want to leave these things to chance. And I think these days, what was I saying? So over 10 years ago, so 13 years ago, I would have practiced for that cricket interview for 2 weeks to a month. And it's an arms race. So it seems like people practice more and more for these things, unfortunately. So yeah, I think anyone who's just practicing for a week or two, that's probably not enough.
Yeah. And again, like it does make you a better candidate and a better registrar overall. Like nothing you do is just for the pure sake of getting on. It actually, I think, in a lot of ways, does make you better at your job. Yeah, so prepare early. Please don't wait to get an offer. For most people, that's too late unless you're really lucky. And again, I'll ask lots of people to help.
Thanks, everyone. Thanks for listening and watching. So that's the end of this episode. The next episode, I'll share my experiences of being on an interview panel, especially because it's so different. It's a different ball game now. The fact that we're on Zoom and there's a lot of subtleties with that. And so, yeah, that's what we'll go through next episode. But something that me and Kaz wanted to volunteer was if anyone wants to be interviewed in person for their own practice, such that it's on YouTube and on this podcast, please email us at anaesthesiapodcast@gmail.com. So that was part 5 of this series. So we'll go through part 6, which will be my experience of being on an interview panel. Thanks very much, and we'll catch you next time.
See you then.